A trauma patient receiving packed red blood cells, PRBCs, develops chills, fever, 101.8 degrees Fahrenheit, headache, and anxiety 35 minutes after the transfusion starts. The nurse stops the infusion. What is the priority action after stopping the transfusion? Administer PRN diphenhydramine for allergic symptoms. Send blood and urine specimens to the lab for hemolysis evaluation. Give PRN acetaminophen to reduce fever and discomfort. Draw new blood for type and crossmatch. Correct answer, 2. Rationale. Priority is diagnosing the reaction type, e.g., acute hemolytic, febrile non-hemolytic, bacterial contamination. Lab tests, plasma hemoglobin, urine hemoglobin, are critical to rule out life-threatening acute hemolytic transfusion reaction, AHTR, or sepsis. Diphenhydramine is useful for allergic reactions, hives, itching, but not fever/chills. Acetaminophen treats symptoms but delays diagnosis of the underlying cause. New crossmatch is unnecessary until the reaction type is confirmed. The knowledge. Febrile non-hemolytic reactions is most common blood transfusion reaction, which caused by donor leukocyte antibodies. Treat with acetaminophen after labs are drawn. Acute hemolytic reaction, HTR, is a medical emergency since it caused by ABO incompatibility. Typical sign and symptom are fever, flank pain, hemoglobinuria, hypotension. It can lead to renal failure/DIC if leaving untreated. Never restart the transfusion until the reaction is fully investigated. Key actions for suspected transfusion reaction. Stop the transfusion immediately. Maintain 4-axis with normal saline, 0.9% NS, for possible resuscitation. Notify the provider and blood bank stat. Send labs/urine to evaluate for hemolysis. Blood, plasma hemoglobin, direct antiglobulin test, DAT. Urine, hemoglobinuria. Monitor for complications, hypotension, renal failure, DIC, or sepsis. The trauma patient's lab results confirm an acute hemolytic transfusion reaction, HTR, due to ABO incompatibility. The provider orders immediate interventions. Which action should the nurse take first? Initiate a normal saline bolus and prepare to administer vasopressors. Insert a Foley catheter to monitor hourly urine output. Administer 4 corticosteroids to reduce immune-mediated hemolysis. Collect a second urine specimen to reconfirm hemoglobinuria. Correct answer, A. Rationale. AHTR causes hypotension and shock due to massive hemolysis. Fluid resuscitation, NS bolus, and vasopressors, e.g., norepinephrine, are prioritized to maintain perfusion and prevent acute kidney injury. Foley is important but secondary to stabilizing circulation. Steroids is not evidence-based practice for AHTR unlike allergic reactions are confirmed. Repeat urine is unnecessary since initial labs already confirmed the diagnosis. Key interventions for AHTR. Aggressive 4 fluids, 0.9% NS, to maintain renal perfusion. Vasopressors, for example, norepinephrine, for refractory hypotension. Monitor for complications. Renal failure, strict ANO, BUN/creatinine trends. DIC, check platelets, fibrinogen, PT/INR. Avoid diuretics such as furosemide until volume is restored. Key patient education for future transfusions. You'll need special compatibility testing before any future transfusions. Report chills, back pain, or dark urine immediately during transfusions. Wear a medical alert bracelet indicating your transfusion reaction history. A trauma patient develops oliguria, less than 30 milliliters per hour urine output, 2 hours after an acute hemolytic transfusion reaction, AHTR. The nurse reviews the provider's orders. Which lab test should the nurse prioritize stat? Serum potassium. Complete blood count, CBC. Liver function tests, ALT/AST. Repeat direct antiglobulin test, DAT. Correct answer, A. Serum potassium. Rationale: hemolysis releases intracellular potassium from ruptured RBCs, causing hyperkalemia, peaks within 6 to 12 hours. This can lead to cardiac arrhythmias, e.g., peaked T waves, ventricular fibrillation, muscle weakness/paralysis. This condition requires immediate treatment, calcium gluconate, insulin/glucose, Kayexalate. CBC will show anemia but is less urgent than hyperkalemia. LFTs may indicate liver damage, which is a slower complication of AHTR. Repeating DAT is unnecessary since diagnosis is already confirmed. The knowledge. Potassium spikes in AHTR since each unit of hemolyzed blood releases 250 milliequivalent of potassium. Renal failure from hemoglobinuria exacerbates hyperkalemia. Cardiac monitoring is critical. Look for muscle twitching, which indicating early signs of hyperkalemia. Look for urine color. Coca-Cola colored urine suggests hemoglobinuria. Key interventions for oliguria plus hyperkalemia. Stat EKG to check for peak T waves, widen QRS. Administer calcium gluconate to stabilizes cardiac membranes. Give insulin plus glucose to shifts K into cells. Prepare for dialysis if K greater than 6.5 milliequivalent/L or refractory to treatment. The trauma patient develops oliguria, 20 milliliters per hour output, and EKG changes, peak T waves, after an acute hemolytic transfusion reaction. The nurse receives these stat lab results. Potassium, 7.1 milliequivalent/L, critical high. Creatinine, 2.8 milligrams per deciliter, baseline 0.9. Hemoglobin, 5.3 g/dl, transfusion interrupted. Which action should the nurse take first? Initiate a sodium polystyrene sulfonate, Kayexalate, enema. Administer 10% calcium gluconate for over 10 minutes. Give 4-furosemide 40 milligrams to promote diuresis. Prepare for emergent hemodialysis. Correct answer, B. Rationale: immediate cardioprotection is needed. Calcium stabilizes cardiac myocyte membranes to prevent lethal arrhythmias, e.g., VFib. Works within 1 to 3 minutes. The mechanism is involved counteracting potassium-caused depolarizing effects on myocardium. Kayexalate will be too slow since it takes hours, which is used for chronic hyperkalemia. Furosemide is contraindicated until volume status is confirmed since patient may be hypovolemic from AHTR-induced hypotension. Dialysis is critical for refractory hyperkalemia but requires vascular access and setup time. Hyperkalemia is when blood potassium levels are higher than 5.0 milliequivalent/L. Since potassium plays a key role in muscle and heart function, high levels can be dangerous. Causes of hyperkalemia: kidney failure, impaired excretion. Medications: ACE inhibitors, ARBs, potassium-sparing diuretics. Tissue damage, burns, rhabdomyolysis, hemolysis. Metabolic acidosis, e.g., DKA. Excess potassium intake. Symptoms: muscle weakness, arrhythmias, palpitations, ECG changes, fatigue, paralysis, severe cases, ECG changes, mild, 5.5 to 6.5 milliequivalent/L, peak T waves, moderate, 6.5 to 8.0 milliequivalent/L, widen QRS, prolonged PR. Severe, greater than 8.0 milliequivalent/L, sine wave, risk of cardiac arrest. Management of hyperkalemia. 1. Stabilize the heart. For calcium gluconate, stabilizes cardiac membrane. 2. Shift potassium into cells. Insulin plus dextrose drives K plus into cells. Beta agonists, albuterol. Sodium bicarbonate if acidosis present. 3. Remove potassium from the body. Loop/thiazide diuretics if kidneys function. Sodium polystyrene sulfonate, Kayexalate, binds K plus in the gut. Dialysis for severe or refractory cases. Emergency red flags. ECG changes. Severe muscle weakness. K plus greater than 6.5 milliequivalent/L with symptoms. Early recognition and rapid management are life-saving.